Hello, and welcome to the Longev Lens. Please join my co-host, Dr. Sebastian Pedersen, and I as we cut through the noise and hype around longevity, health, and wellness, and turn the latest evidence into honest, practical insight for living better for longer.
And just a quick disclaimer before we dive in, this podcast is for educational purposes only and doesn't constitute medical advice. If you have a healthcare problem, please consult your doctor or qualified healthcare professional.
Welcome back to the Longev Lens. Episode 2, we'll be talking about all things sex hormones. Before we actually get into that, I just wanted to say a massive thank you to all of our audience and all the feedback, all the support, all the subscribing, sharing, everything that you've done from the first episode. We're incredibly appreciative of it. And it's super important for us because we want to make sure that this information actually gets out to you and it's understood and that you can take it on board and it's all actionable. So we just want to say from the bottom of our hearts, thank you very much. Dr. Seb, thank you again for joining me today. We're going to go through sex hormones.
Yep.
It's a really confusing and conflicting and it's a massive topic. Why do you think that it actually is such a confusing topic with the hormones?
Yeah, I think there's history of controversy with good and bad science being thrown in. There's very strong opinions in this space. And I think it's, for me personally, and I know for you as well, it's important to really break it down, simplify it, understand it, and make it actionable. What do we actually need to do, or what do we need to be aware of so that we can maximize overall health and also our sex hormones?
So what does good hormone health actually look like?
Listening to the person. It always comes down to listening to the person, being aware of taking on board what they're saying, and also trying to achieve the best outcome for them. So for hormone health, especially for females, it's very much it's symptom-based, which is why this area of medicine is so beautiful. You're not relying on blood tests. You're not relying on imaging. You're just relying on the person in front of you, what they're dealing with, and then you're trying to help them. Males is a little bit different. You do rely a little bit more on blood tests than you do for women. And I think for me personally, it's a matter of, I really feel that every doctor should be aware to do this, should be able to do this, It should be bread and butter medicine, but I feel that a lot of doctors are underprepared to have this conversation about sex hormones with patients, and they refer on very quickly to other doctors, which is interesting because we all have sex hormones. So it's like cholesterol. We all have cholesterol.
Yeah.
So I do believe that every doctor should be able to at least know enough to be dangerous to help people with simple sex hormone changes with age. Of course, if there's a specific condition or an underlying disease or a hormone abnormality, then yes, refer on for specialized support. But there needs to be bread and butter medicine, and I really just want to simplify it, I guess, is my strong intention from this podcast.
Do doctors or GPs or just medicine in general, outside of being an endocrinologist, like a hormone specialist, do you actually get taught much of it?
Through your undergraduate degree, you don't necessarily. There's like maybe one semester where you get a bit of overview of all hormones, not just sex hormones. So it's very brief.
Yeah.
And then depending on which specialty you pick, some have more exposure. GPs have more exposure than, say, a general surgeon or a cardiologist. So it's very much a field of what you decide which specialty you decide to pursue. But also if you have special interest in it. So for me, I have a special interest in it, so I have to upskill in my own spare time outside of what was my training program.
So what are the hormones that we'll actually be focusing on mostly today?
So testosterone, estrogen, and progesterone are the big three that we'll focus on. You can add in there DHEA, but I really just want to keep it simple today, and just to make sure people find value in this and know what to be aware of for themselves and their partners, because we're two males sitting here. We aren't females when we're talking about female hormones, but I think that's important. Males need to have these discussions and need to be aware of what to look out for in female partners, in family members. But also there doesn't need to be any stigmas about males talking about sex hormones or trying to achieve the best outcomes for their female patients or female clients.
Yeah, I think that's exactly right, because we're both treating women who are in their 40s and 50s, and there will be a lot of males in the same position. So I definitely think it shouldn't be brushed off. Like women's health, I think we've sort of found that it wasn't until like 1993 that women were actually required to be in studies, so we've only got like just over 30 years of research in this sector, whereas before it was just thought, there's too much variability with women's health.
Exactly.
And yeah, again, I feel like a lot of people might look at us and say, yeah, look, you guys are two young males, you don't know what they're going through. And we're never going to either. Like I'm not arguing that at all. But we do definitely need to know more about it. Exactly. And I think especially from your perspective in like the rehab specialist field, like you're encompassing everything. And hormones are such an ebb and flow balance that needs to be maintained. As it's never just about keeping hormones as high as possible for as long as possible or anything like that, is it?
Exactly right. No, it's spot on. It's a matter of improving the quality of life and their functional ability for both females and males.
Yeah, yeah. And like I said today, we wanted to start off with the women's health.
Yep.
In particular, this got spurred on because we had another one of our clients that has been going through menopause. And also wanted to know more about perimenopause, but this came from like a rapid fire question, which we thought this is a huge topic. Yep. This deserves way more than 15 minutes. So that's where we wanted to start today. What do you think are probably the biggest things? Let's start with perimenopause that people should be knowing about to start off with.
I think let's start with menopause. So menopause is not just the end of reproduction. It's a major biological transition. And it usually women encounter menopause between the ages of 45 to 55. That's the normal range. But 10% of the women population can have menopause below the age or earlier than 45. So keeping that in mind, perimenopause, women can start to develop perimenopause 5 to 10 years before menopause. So if you do the maths on that, if you are going to experience menopause at 45, you could be experiencing symptoms at 35. Or if you're on the 10% demographic that have earlier onset menopause, then you could be experiencing symptoms in your early to mid 30s.
Yeah.
And I think that's something I really wanted to get out today, that my partner's now 30. It's something I need to be aware of. I need to upskill to not only her responsibility, but it's also my responsibility as a partner to be aware of what's happening with her body as we're aging together in our relationship. So I think being aware that you can start to get symptoms in your early to mid 30s is very important.
Yeah, I think it's spot on, because that was something we wanted to touch on, the fact that a lot of people might think, oh, I don't need to worry about this. This is another 10, 15, 20 years away from me. But hang on, it could actually start a lot earlier than we think. So it might be very beneficial and empowering to know what sort of symptoms are you looking for.
Exactly.
That could go down the pathway of this.
Yep.
So just start off with, what is perimenopause?
Yeah, so that's when your hormones change and you start to develop symptoms. So it's usually lack of sleep, changes in libido, changes in mood, loss of bone density. So it's hot flashes. So a variety of different multi-system symptoms that changes with hormones. But also around the perimenopause period, there's a lot of focus on just estrogen and progesterone. Everyone's thinking, oh, okay, yes, if my estrogen and progesterone drops, I'll need to be on menopausal hormone treatment or HRT or hormone replacement therapy. But I think, again, it's underappreciated that testosterone is actually the first hormone to decrease. So between the ages of 20 to 40, females have a 50% reduction in the testosterone. And then after that is when you see a 90% drop in estrogen, and then progesterone almost disappears as you age through middle age and beyond. So that flipped mindset of, okay, testosterone actually drops first, then estrogen, and then progesterone declines slowly, is something that I'm super interested in. I'd love to see more studies in this field. Is the menopausal period also partly due to testosterone, or is it just the rapid 90% reduction in the estrogen?
Because that would cause an absolute chaos. Like if any man was to
Imagine
lose
that.
90% of it,
the 50% testosterone and 90% of estrogen within a decade, it's phenomenal.
Yeah, that is why. And like already to start off with, like women's testosterone is at what, a tenth of
Much
the levels
correct.
of what men's is?
Yeah.
Is there, so when, if someone's getting, or they feel like they're getting perimenopausal symptoms, when do you think would be best sort of to go and test or go speak to a doctor? Should it be based on the labs, like blood test results, or is it purely symptom based?
Yeah, good question. I think something that people can do to really take control of the situation is get more data when they do go to see their doctor or their healthcare professional. One of the validated questionnaires is called the Modified Green Scale, Green, GREENE, and it's what the Australian Menopause Society recommend. And that's something you can download, and then it's got all the symptoms that you would expect throughout the perimenopausal period, and then also ranks them in terms of severity. So if you think you're starting to experience symptoms, start filling out this document so that when you do go to see your doctor, you have objective evidence as to what it is, because often it can be hard to explain. I'm just a bit tired, or I'm having some hot flashes, but having that objective data written down is super informative, not only for yourself, but also when you do go see your doctor. And I'll add on that, just importantly, it's important for males or partners to be aware of this questionnaire also, so that they can recommend to their partner, how about we start doing this symptoms, start completing this questionnaire now, so that they're on board as well as how their partner's feeling or what they're going through.
You said it was the modified green.
Modified, a green scale, correct.
Yep.
And there are some cutoffs in terms of when you would consider treating someone, but I don't want to give that number here on this podcast, because for me, you could have 5 symptoms all at a scale of the 1, or you can have the highest severity of 1 symptom, and that may be debilitating enough for you. So I don't really want to just give like a cutoff to say this is when you should start treatment, because it's super personalized based on how many symptoms and the severity of the symptoms that you're experiencing.
Okay. And if you were to go down, like, because obviously a lot of people are going to visit their doctor, they're getting blood test results in perimenopause and things like that. Should they expect to actually see any changes?
You will. You definitely will. But it's important not to treat blood tests, especially within perimenopause and menopause. You're treating the person in front of you. So when you go see your doctor, is common is that the physician or the doctor is most likely going to rule out other causes. So make sure there's nothing else going on in the background, whether it's an over or underactive thyroid or any other organic conditions.
There'd be a lot of overlapping.
That's exactly right. So once you've ruled out other causes, and based on the age of the individual, then that's when you need to have the discussion. Is this something that we're going to try? And if so, what are we going to start? How often are we going to monitor? And the big one is also making sure that there's no contraindications to starting treatment for menopausal hormone treatment.
So what sort of treatments would be in mind if that was the case?
Yeah. So the biggest one is, it's always a hierarchy. You always start with estrogen and progesterone. Bioidentical hormones is the best.
What does that mean exactly?
That means it's as close to your own hormones rather than synthetically made hormones, because what we found out earlier, a couple of decades ago now, was that the hormones that weren't necessarily bioidentical or identical to your own hormones were the ones that had higher risk of, for example, breast cancer. So we know that bioidentical hormones don't increase your risk of breast cancer. And in terms of bioidentical hormones and breast cancer, it's the progesterone. So you need micronized progesterone, and that doesn't increase your risk of breast cancer for at least up to 5 years. We don't have any long-term studies beyond 5 years. So good medicine would say that, yes, within 5 years, there's no increased risk, but it is good to continue monitoring for potential side effects of this treatment as well.
So is that why the hormone replacement therapy sort of dropped off for a long time as well, because of these risks that kept on coming about in terms of breast cancer risk and that sort of stuff?
Correct, and not only breast cancer. Obviously, there's still risks that we know, such as blood clots as well, but even the other risks like heart disease and also dementia. They're all sort of, what we know now is they're all because the study, like the Women's Health Initiative, the average age of a study subject was 63. So they're sort of well beyond menopause.
Potentially 15, 20 years beyond.
That's exactly right. And we know that the timing hypothesis is key in this field, that if you start hormone treatment less than 10 years after menopause or less than 60 years of age, there is no increased risk of heart disease, and it may actually be protective, especially for coronary artery disease. And the same with dementia. It doesn't increase your risk of dementia if you start within this period, and it may actually improve your executive function and your memory.
So what? So what if you've started after it? Is there any
Correct,
to
and
that?
that's when there's risks. That's when you really need to have a detailed conversation with your doctor, because that's when the evidence does show that if you start it beyond that age group, beyond 10 years or beyond 60,
After menopause?
exactly,
Yeah.
exactly, then there's an increased risk of breast cancer, of heart disease, and of cognitive disorders.
So, and that's from having, like, if you started after 10 years, that's starting the HRT, or
At
is
that point in time, correct. Yeah, if you
okay,
haven't had anything prior. And a good question there is, and I often get clients asking me, but what if I stop it? What if I've been on it since I was, say, within the perimenopause and I've been continuously on it? What if I then, something happens, I'm unwell and I stop it? Can I then go back on it because now I'm beyond 60? In that case, it's different. You can continue it. But the important distinction here is you don't ideally want to start it after the 10 years post-menopause or beyond the age of 60.
Okay. Again, when we're talking about dementia as well, if dementia is affecting 2/3 of the dementia cases within Australia, at least that we're aware of, they seem to be at the biggest risk of it. Is that because of there's like estrogen effects, or because estrogen has a very protective effect on the brain? Is that because there's been such a big chaos and just a complete drop?
Yeah, there's
those
definitely a
hormones?
massive association there.
Okay.
Whether I can see that, at this level of estrogen, you're going to be protective or lowering a risk of dementia. We don't have that evidence, and I won't be able to clearly articulate that just yet.
Okay. So how does let's just go through more of like the natural conservative measures. How does nutrition and sleep play a role in hormone health?
Yeah, and very important. So all the lifestyle behaviors, so sleep, exercise, nutrition, stress management, are very important to improve your overall health and well-being. But they don't, not for women, don't directly influence or significantly increase your or improve your symptoms or increase hormone levels. So it's still the foundation to have to improve your overall quality of life, but it's not directly a treatment for what happens to the hormone decline.
It's kind of like men. There's not really a specific treatment or supplement or anything that directly hits the testosterone. So it's similar sort of women. Like there's interplay.
Males. I mean, we'll touch on that later. Males is more evidence. For males, it's definitely lifestyle is the best testosterone stimulus, rather than just testosterone replacement. For females, it's not the same. You still want to make sure you optimize your lifestyle, but it doesn't have the direct stimulus to improve your hormone levels and your symptoms you're dealing with through perimenopause and menopause. Okay.
And so we touched a little bit on perimenopause and what that is. So what is menopause?
So when you've completely had your last period and there's no ongoing menstruation.
Okay, and again, like a hormone changes are more dramatic there?
No, that would be, so the menopause, the testosterone, estrogen, progesterone, they sort of start changing throughout the perimenopause period, and sort of around the menopause period after that, they're relatively stable. So there's not a huge change after menopause, it's just that leading up to and around menopause that the hormones change.
Okay. So how would you approach midlife woman who's coming to you about this and they feel like they're doing everything right in terms of their lifestyle, avoiding alcohol, sleeping well, or trying to do that as best as they could? What would sort of be the recommendations that you'd be going through with them?
Yeah, so my first priority is always, that'll be the back of my mind, that is, could be perimenopause and menopause, but exclude other causes. Do some tests to make sure there's nothing else going on. And then, as I said, get some more data. Use the validated questionnaire, get the data, see what the person in front of you is suffering with, because often if they're suffering, it can be difficult for them to recall all of their symptoms over days, weeks, months. So start getting them to fill out these questionnaires, so when they come and see me, I have data to show that, okay, they're really struggling. It's really impacting their quality of life and their daily function. And then that's when we have the discussion about potentially starting MHT or HRT. And then for me, it's a matter of, okay, well, are there any contraindications, any reasons why they shouldn't be on MHT or menopausal hormone treatment? If not, and if they're symptomatic or if they have issues with bone health, then it is a no-brainer to start people or start women on estrogen and progesterone. Whether that's cyclical treatment or non-cyclical depends on where they're at in their menopause journey, and we can go into that at another time. And then the question then comes after, well, what about testosterone? I know that we get asked that a lot as well, but for me, it's start with the estrogen and the progesterone. Best evidence is mostly for the topical estrogen, so patches or gels with oral micronized progesterone. And when I mean estrogen, it's estradiol, so E2.
Yeah.
And then testosterone, there's most of the evidence with sexual disorders of perimenopause and menopause for using testosterone. But if someone's on maximal estradiol and micronized progesterone and they're still not having a great response, then you would consider testosterone. But for me, it's always you want to add one treatment at a time. Don't throw everything at the person at once, because you need to know, okay, does this treatment change the women's symptoms and their function? If it does, great. If it doesn't, that's when you add another treatment on top, rather than just throwing estrogen, progesterone, testosterone at the same time in terms of treatment. I guess the only thing I would add to that is monitoring. You'd want to make sure you're monitoring the person every 3-6 months, and after they've been on it for 3-6 months, it can be less frequent. And if it's someone who doesn't have any contraindications, don't develop any issues whilst being on this treatment, it can be lifelong.
Yeah. Okay. And when you say monitoring, you're also factoring like the blood tests.
Yeah, other blood tests.
Well?
Correct. Just to make sure, to see if there's anything underlying, and making sure they're educated on risk of clots, so when they're traveling and things like that. So you just want to make sure that the treatment is still the best course of treatment as they at each interval as they age. So reassessing is pretty much the best way of saying you want to reassess the treatment you started this person on at regular intervals to make sure that it's the best thing to do.
Do you find it's actually difficult to monitor women's hormones because they are fluctuating so much through each week? Like, is there a perfect time, or is there any better time that someone should be coming to you throughout their cycle if they're in perimenopause or?
Yeah, so that's again what's the beauty about this treatment is it's so dependent on the person. It's good medicine. You listen to the person in front of you. But you don't want to be, if they're younger, if they're not in perimenopause and they're having a normal cycle, then yes, if you're looking for specific conditions or diseases, you can test hormones. But you don't want to be, for women who are going through perimenopause, you're not trying to get a blood test to tell you what to do.
Yeah.
So you're not trying to time when to do a blood test. And the only thing I would add with perimenopause is women on contraception. It can mask symptoms of perimenopause. And why that's important is if you're having while you're having the hormone break during the contraceptive period or the treatment, then that's when you want to monitor your symptoms. So you don't want to monitor your symptoms whilst you're on the hormones. It's the week or the days off it that you assess. And if you're not quite sure what's going on, then you could get the person to have 2 weeks without hormones, just to really get a proper picture of what's happening. It doesn't change when menopause hits, but it can make it more difficult to predict when they're going through perimenopause.
Okay. All right. Awesome. Is there any things like taking away from this?
Yeah.
Is there any things, maybe like 2 little summaries that you want to say for women who are potentially going through or like the sort of mid-30s, maybe thinking about their perimenopause coming on, or menopause as well?
Yep.
What would sort of be the big couple of things that you want them to focus on?
Be aware of the symptoms early. So even reading that questionnaire I keep talking about, I know I'm harping on about it, but it's just super informative, even just reading the symptoms of what you could be going through and then presenting that to the doctor. So having the data and then making sure that you're getting personalized treatment that's assessed at regular intervals. That would be the key. And I think as males, I know we talked about this at the start, males also need to be not fearful of because it's relatively simple medicine. It's just underappreciated. And for me, it's just making sure that the women's are having personalized treatment that's helping them through a difficult period improve their quality of life and health span.
Yeah, I think that's a massive part of it that really should be focusing on. And you were touching on testosterone a little bit there before, which we want to dovetail into more of like the men's side of health as well. Because men it's not probably widely known, but they can also go through an andropause. From what I can tell, it's obviously not as dramatic, or it may not be as dramatic. But what would be the things that men might need to be focusing on from, typically we know that once people hit 30, things start to change and they go through ebbs and flows.
Yep. So males, they also have symptoms. So it's usually loss of motivation, loss of libido, mood changes, loss of muscle mass or strength. And exactly as you said, men have not as dramatic as a hormone change. It's usually around the age of mid-30s, 35, that hormones or the testosterone starts to decrease by about 1% per year. And similarly, there is a questionnaire you can use for males to be aware of symptoms up front. So if you're in your late 20s, early 30s, or even 40s and 50s, just to be aware of what could happen in the future. It's called the Aging Male Symptom Score, or Aging Male Symptom Score, AMS. That again, you can use to assess your symptoms over time. But what you mentioned earlier when we were talking about testosterone in women is that not all low testosterone for male, though, is pathological. So lifestyle for males is the best and the first treatment option. So that's making sure you optimize your body composition, your exercise, your sleep, your nutrition. In terms of exercise, it's both cardiovascular and resistance training. For sleep, it's quality and quantity and consistency of sleep. And then for nutrition, it's very much lean protein, healthy fats, whole grain carbohydrates, fruits, veg. So it's just a healthy overall diet. And that's going to have the biggest stimulus for maintaining and improving testosterone.
Do you actually see that there's a lot of men out there that might have lower total testosterone, lower free testosterone, that they're functioning perfectly fine, healthy, well, like they're vibrant,
Correct.
recovering well from training, all that sort of stuff?
Correct, and that's what makes this field more difficult. In that you're guided a little bit more by blood tests in males, but you don't want to treat a blood test. You have to combine the results with the person's symptoms.
Okay, so how would you go about that in terms of symptoms? Because it could just be normal aging, or is it actually, have they actually had a sharp drop and sharp changes in their symptoms?
And I think, the guidelines recommend if you have unequivocally low total testosterone and free testosterone on multiple occasions, and you have symptoms, and you've got true evidence of hypogonadalism, then that's when you would warrant testosterone replacement therapy. But where there's a bit of a grey zone is the bell-shaped curve. So if you have someone, you test them in their 40s and 50s for their testosterone and their free testosterone, and let's say they're in the 15th or 20th percentile, so just a little bit below average, but they're not unequivocally low per the guidelines. Where it makes it difficult is you don't really know where this person was when they peaked.
True. Yeah.
So you could have someone if you have someone who's got a baseline testosterone and free testosterone in their 30s, and they would have been in the 95th percentile, and then over the next 15 years, they really only should have been dropped 15%, but they've dropped a lot more than that. That's when it gets grey, because the guidelines still don't recommend treatment because you're not unequivocally low. But again, you really have to take on the individual and the symptoms they're dealing with. If you've excluded all other causes, that there's nothing else going on, and you have a one-on-one discussion about pros and cons, perhaps it's worth the trial, perhaps it's not. But even if it is worth the trial, it'll be time limited, very controlled, regular monitoring, because you're just not following the guidelines. But again, you're just trying to cater for that individual that you're seeing.
When you come back to assessment, the reference ranges are quite. They're quite large for what like the normal population is. Which I've had a lot of my own patients tell me, I don't want to go get tested for normal ranges of, like when you look around 60-70% of the population normals are obese, they're metabolically unwell.
Correct.
People don't want that. They want optimal. So when you have like such normal or large normal reference ranges, are you trying to aim for the upper end of normal? Are you trying to aim for middle or what is it?
I mean, I wouldn't, if I was to start someone on testosterone replacement, I'd never target a blood result.
Okay.
It would be purely what are they doing and how does it improve their symptoms and what we're trying to achieve. If someone comes in with all the symptoms, low libido and low motivation, which impacts then their professional life, they can't work, impacts their sexual life, their relationships. So someone's dealing with all these complex issues and it impacts their quality of life, then that's what you would target. You wouldn't target a blood result and say, okay, now I'm happy. And to respond to people who are on super therapeutic testosterone, I know there's, testosterone clinics out there doing and I've seen one of these results where I was like absolutely gobsmacked with the results of this person's testosterone based on the treatment they were on.
What were they?
They were very high. Very high. I wouldn't. Yeah, just above what the upper limit of normal that the machine can actually detect.
Yeah, right.
So
Okay.
very high.
Yeah,
So I didn't even get the crude number, the actual
Yeah.
number. It was just above the entire what the machine could test, and that's when I get concerned. When people are targeting results rather than trying to improve this person's life and health span.
So what would be the flow-on effect? So you've got that person.
Yep.
There's super-physiological levels of T. What's the flow-on effect there?
And that's when it makes it really difficult. I mean, the side effects of elevated testosterone is you get blood-related side effects, increased hemoglobin, risk of sleep apnea.
Like thickening of the blood?
Yeah, correct. Increased risk of, you can have cholesterol abnormalities, kidney abnormalities, liver abnormalities. It can reduce your fertility. So if you're in the reproductive age, you don't want to be using testosterone if you're about to be fertile, or if you're going to try to become, trying to have children. So, and the hard thing about this is you can't really feel these symptoms. Unless you're end-stage liver disease, end-stage kidney disease, you can't see this. So you think you're doing amazingly well, and these super therapeutic individuals that I've seen aren't being monitored at regular intervals either. So they're having a very biased opinion of how their health is because they feel great, but they don't have the data to say, well, is this actually causing any damage concurrently?
I think that's where the problem is that people feel amazing.
Yeah.
I've had a lot of my patients say the same thing. Like they feel unreal. You should get on it. Like you feel like you're invincible. You can train constantly, but I know for certain a lot of them have not done a lot of the other blood work that it probably needs to be done, even if we're looking at cancer sort of prevention or like assessment through that, or have they done any scans that might go through exactly what you've just said?
Yep.
Like,
So I mean, so testosterone itself doesn't increase the risk of prostate cancer, but if you have a history of breast or prostate cancer, it may impact or it may actually promote the growth. Yeah. And that's an important distinction. So it doesn't increase your risk if you don't have a history of it, but if you have had a history of cancers, it can increase your risk of recurrence or spread. So that's what's one distinction in terms of cancer to be aware of. But it's difficult, and a lot of it comes down to education. You really have to have time with these males, young males, motivated males who are wanting to feel great. And these are difficult discussions to have and usually requires multiple consults. You're not going to solve the problem in the first consult, which is sometimes difficult, but you just have to, we've gotten through what I wanted to get through today. And the hard thing is with the current climate is if you don't, it's important to not just to treat based on what they want, but if you don't listen to them and provide them follow-up, then the likelihood of them just going to one of these clinics is quite high. So you have to build rapport to actually look out for their best, have their own health and have their health and their best interests at heart. But you also have to be mindful that they may pursue elsewhere.
Well, that's the thing. Like that's why we want to do this because, like, I've considered it massively, but I've also considered all the other risks, and I've had to educate myself on that because there's probably a lot more than I'm even aware of. Like I even saw maybe 2 days ago a 22-year-old bloke with like a promising bodybuilder, obviously on a lot of gear and super physiological levels. He died. So whether that was like, I can't remember if it was like an immune response or was it because of cardiovascular risk, but like 22 years old, there's not a chance that I would want to put myself in that risk for a certain look, which I think people need to know more about, that there is serious consequences if it's not done well.
Correct.
But on the flip side, what can change if you're looking to put someone on TRT, like let's say they've done all the lifestyle modifications, their sleep's been consistent, they've been perfect 8 hours for 6 months, they've dropped fat, like they've dropped visceral fat, all the fat around their body, around their organs, they're training consistently, they're hitting the VO2 max tests, they're doing all that sort of stuff. What would you be considering as let's try to get you along just a normal pathway of TRT? Yeah.
So if there's no issues, no contraindications, and they're not trying to have children, and they've got evidence of hypogonadism with low testosterone, then there's two main treatment options. There's intramuscular and there's topical. So intramuscular is an injection. You'd have that every 3 months-ish. That's more evidence for that type of treatment to improve muscle mass and muscle strength, but also more risk of side effects. And because it's a 3-monthly injection, it's not as continuous a treatment.
Yeah, that is that a really big dose?
It is. It's 1,000 milligrams. Yeah, 1,000 milligrams to start off with.
Okay. Yeah.
And then you have the 1% creams or the gels, where it's daily, less side effects, more stable levels, but you just have to be careful of if you have any skin irritation to things you put on your skin, creams, and also if you make sure that when you're putting it on at the time of day where you're not going to be touching your partners, your children, things like that.
Yeah.
So I mean that's the pros and cons, and it's super individualized. If you have someone who's not compliant, doesn't have any concerning contraindications or concerns, then they may be someone where you do the injection because they wouldn't do it daily. Whereas then they have to be aware of the side effects, the increased risk of side effects. But you have someone who's compliant, wants a more steady dose, and can monitor making sure they're not transferring it to someone else, then that might be someone who the gel would be better for.
I had heard of that when you're talking about the gel. Like you've obviously got to use your hands.
Yeah,
I've heard of someone who did that, and then obviously they were hugging their children and stuff, and then those symptoms were also the effects of it were actually passed on.
Yeah, correct.
Like that's terrifying.
Yeah, it is. So like you put it on, you can either cover it or you put it on. You put it on at night. You make sure you're sleeping by yourself, or at least there's a gap between you and your partner. You have to make sure, depending on where you're putting it on your body, there's a t-shirt on top of where you're putting it on. And if it does go through the t-shirt, you're washing sheets. So it's just a little bit more things you have to consider.
Yeah, practically.
Yeah, exactly. From a practicality perspective, yeah.
Could you also consider, or I don't know, from a medical perspective, would they do maybe like once or twice a week sort of doses that are a much smaller dose to try to, as you say, like try to just keep a fairly steady
as for the injections
level? Yeah.
I mean, theoretically, those are the two gold standard options. Whether you want to find somewhere in between, I haven't seen that or done it in that sense.
Yeah.
Whether it can be done, I actually don't know.
Yeah. Okay. Yeah. I'm sure there's lots of people just shooting up in gyms.
Oh, I could imagine. Yeah. Well, I don't think their long-term health or risks or the right dosing is of paramount importance there, which is concerning. And I think that's where we can do better as a health profession to really get out the information that if people are aware of the side effects, more aware of it, rather than just seeing the good-looking person who's on it at the gym, you want to try to replicate because you're young and you want to do what you can do for your own mental health or your own self-esteem and things like that. It's where we have a long way to go with educating our youth, and hopefully we could be a part of that.
Yeah, absolutely. Because like once you're on it as well, you pretty much have to be on it. Is it forever? Like if you're
depends. If you're on it for if you're on it for pure issues with there's an organic reason why you're producing low testosterone or free testosterone, then yes, you can be on it lifelong. But for some people, depending on the situation, it can be temporary.
So how long would temporary be?
It could be months to years rather than necessarily decades or longer.
Okay. So there's going to be lots of males, and obviously some females too, that are on like the super-physiological levels of testosterone. They're going to do it probably regardless. As you say, they've probably just gone to another doctor or another clinic or something. What would be your recommendations for those that are going to do it anyway? What should they be assessing for that they mitigate any sort of risk as much as possible?
First one is let the people around you know that you're on it. Don't hide it. Let your partner, let your family know, just from the sake of they're going to be providing unbiased opinions on changes with your behavior, changes with your mood, changes that you won't necessarily notice. That would be the big one. And then also make sure that you're still seeing a doctor. Just be honest. Doctors will want to help you. Doctors are very much, I still believe doctors are advisors more than they should be gatekeepers. So if you are on super therapeutic doses of testosterone, let your doctor know that this is what I'm on, but I really want to be monitored. So making sure you're checking your bloods, checking your heart, checking your mental health, checking your bones as well, especially if you're on it for a longer period of time, so that the risk that could happen are considered and taken care of. And if something is identified, then at least you know it, rather than just being oblivious to the potential side effects and just being tunnel visioned, I guess, and just being all in on this treatment without considering the potential consequences.
What would be the big things that naturally people could be doing to improve their health? You sort of touched on it a little bit, but like how much does training have an effect on?
Yeah, good point. And that's, I guess that's another thing I'll have to talk about, especially with my performance background with endurance athletes. But so with training, it's, as you mentioned it earlier, you really want to have at least 6-month period of where you're really trying to optimize every lifestyle behavior, and even longer. It could be 6 to 12 months before you start seeing changes. And that's consistent. We mentioned the lifestyle behaviors before, but the training, depending on if you're doing resistance training versus endurance training, if you're doing endurance training, you can actually, if you're overtraining, that's also a suppressor of testosterone. So for these endurance athletes who are usually elite, very committed, I do find it important to also do blood tests of testosterone, because you can do the testosterone to cortisol ratio. And that then shows, it gives you more evidence, because from my own personal experience and being around endurance athletes, if someone has a drop in performance because they're overtraining, the immediate responses do more. Whereas if someone has a drop in performance, you want to make sure the coaching team, everyone is aware of it, and you want to test, and that's also not in testosterone, all the other hormones, micronutrients, to make sure that you have all the building blocks for elite performance. But you want to test this at regular intervals to make sure that you have, so the athlete has that in-your-face data to say, hang on, my testosterone is lower, my cortisol is higher, rather than just with the reflex of training more. Now's the time to back off, rest, recover, so that I can improve my overall performance in the long run.
Yeah. Again, like having that chronic training overload. We also, for those types of athletes, they're usually not fueling themselves enough, 100%. Which comes back to your just your calories, making sure you are getting enough calories to fuel your performance.
Exactly.
Obviously, you want to try to eat as healthy and as well as possible, but having enough carbohydrates, having enough fats, having enough protein to be able to fuel all those physiological processes is pretty much one of the, some of the best possible processes that you could be doing to naturally increase your testosterone. Because from what I saw, a lot of even just training responses, so you're sort of saying from one end of the spectrum, chronic overload, but then from the other end of the spectrum, like if people are doing just resistance training 2 to 4 times a week, awesome, it's excellent, because you're growing that muscle that will help to fuel healthy hormones. But it's very transient. Like the hormone response is actually it might only increase for 30 to 60 minutes, and then you drop off again a little bit more. What I found was most interesting is actually the reduction of your weight and your physical, like your
body
visceral fat, all that sort of stuff.
100%.
That actually had probably the biggest response in increasing testosterone. It wasn't a particular supplement, wasn't a particular training style, or as I said, like you can get some aerobic fitness improvements with improving your testosterone as well, but again they fluctuate so much. So like again, we come back to what we were saying before, that it's the body composition is a huge part of your testosterone care.
It's which please know your body composition. Yeah, absolutely.
Yeah, and like best way to go about that really would be the DEXA too.
Correct. And it's cheap. It's very low radiation, but it just gives you so much data, especially what we're talking about in the hormones, but also risk of cardiovascular disease and other conditions. But absolutely, know those simple data, those simple metrics.
Okay, just to wrap up, so that we can sort of reflect a little bit more so on like your men's health as well. What do you think would be the biggest natural things that we want to make sure we're targeting for them? And then what's sort of the pathway if they were to go down that road as a bit of a summary to finish off?
Prioritize lifestyle, always, and give it time. Don't do something for 6 to 12 weeks and expect it to fix your problem. You have to be consistent and expect 6 to 12 months. Recognize that being aware of your symptoms is very important. Acting thoughtfully, I think, is key. Don't be pigeonholed that I need testosterone treatment to solve my problem. Well, let's take on board what the health professional is telling you, have conversations about it, and then act thoughtfully if you do decide to commit to this treatment. Make sure that you have the right indications for being on testosterone replacement. And if you do decide to pursue a pathway that's unregulated, I guess is a better way of saying it, then please monitor for adverse effects.
Yeah, perfect. I think that's a good way to summarize it up, because again, the natural foundations of all of these topics always comes back to, look, sleep well, eat well, hydrate with like water better as much as you can, and train for your quality of life. It's the biggest foundations that have the largest effects. It's all the other shiny things that they don't actually stack up anywhere near as well as what all the other stuff does.
Correct.
Yeah, perfect. Thanks for your time again today, Dr. Seb.
Pleasure.
That's where we'll wrap up for today. Our next episode will actually be the rapid fire for our stem cells. It's actually super interesting. I really enjoyed going through that one. So join us again for that on the Longev Lens. Cheers.